So this is my third and final introduction for this morning, but I'm really happy to have this opportunity to introduce a friend and colleague, Dr. Kathleen Brady, who is a professor in the Department of Psychiatry and Behavioral Sciences at the Medical University of South Carolina. And many of you know this, but not everyone. Dr. Brady is an experienced clinical and translational researcher, has been conducting scientific investigations and clinical work in the field of addictions and psychiatric disorders for over 30 years. Her research focuses on pharmacotherapy of substance use disorder, comorbidity of psychiatric disorders and addictions, and gender differences in women's issues and addictions, which of course is one of the reasons we've invited her to be with us today, and the neurobiological connections between stress and addictions. Dr. Brady has received numerous federal research grants and published over 400 peer-reviewed journal articles, co-edited 10 books. She is the principal investigator at MUSC's Clinical and Translational Science Award, which is a huge responsibility, and principal investigator of the Southern Consortium node of the NIDA-funded Clinical Trials Network, and director of MUSC's Women's Research Center. Her dedication to furthering research careers has attracted a number of junior investigators and clinicians. Our own Kelly Peck is collaborating with one of her mentees, or former mentees. She's former vice president for research at the Medical University of South Carolina. She has served as the president of numerous scientific organizations, the Association for Medical Education Research in Substance Use Disorders, the American Academy of Addiction Psychiatry, and is the immediate past president of the International Society of Addiction Medicine. So I'm thrilled that Kathleen has agreed to join us for this year's conference in the dual roles as chair and presenter in this next panel. So Kathleen, please come up and take over.
Thank you for that very, very kind introduction. And it's really a pleasure to be here. Such a beautiful place at this time of year. Thanks so much for the invitation. So my talk is, I'm sorry, it's right back here, smoking in women and girls. And I'm going to talk about psychiatric aspects and pharmacotherapy primarily. But let me just start with this data, just looking at survival probabilities. And you can see that for both men and women, that there is a significant decrease in life expectancy as a result of smoking. And it's pretty similar for men and women, about 11 to 12 years. We have been looking at some of the data on prevalence rates, but I wanted to just drill down a little bit more into the adolescent numbers and smoking versus having a nicotine use disorder. But this is the U.S. prevalence rates of people, current cigarette smokers. You can see they've been going down from 2005 to 2015, and even into 2021, 13% of men, 10% of women. So you can see, while the gender differential for a lot of other substances of abuse is about 2 to 3 to 1, when it comes to smoking, the gender differential is much smaller, and women and men, this is the adult women and men, or all ages, are very similar. But when we look at substance use disorders, this is where nicotine use disorders, you can see that in adolescents, the 12 to 17, you can see for adults 12 plus, 18 plus, we're again in that 2 to 1 ratio, but looking for adolescents, the numbers are much closer in terms of men to, or girls to boys. And this holds true across many nations. You can see this is a World Health Organization looking at gender differential male to female ratios of cigarette smoking, and you can see that for most in adults, it's a fair amount higher than it is for women. Either this means that a lot of girls stop smoking as they age, or that we're going to be seeing closer,
men and women get closer and closer in terms of the nicotine use disorder. The other area I think that's really interesting and getting a lot more research than before, which I always get questions about when I give a talk about gender differences in anything, because sexual orientation has become such a big issue these days and such a controversial issue for some reason. But so people are always asking, what about people that identify as different than their gender of birth? And here we have a very interesting plot looking at sexual orientation. In this first graph, this high, highest prevalence right here and really earliest smoking is trans boys. And then you can see the cisgender girls and boys are down here, and trans girls are down here. So you can see this is looks like a very high risk group. Over here, this is just what's interesting. These are heterosexual adolescents. You can see they have the highest and earliest smoking. Right here are gay and lesbian in there, so less at risk. But this was kind of a striking number right here. And this is a number that obviously something that we need to now begin to really investigate much more carefully in our work, since there's we have sometimes 20-30% of youth that are in this category. And if any of those groups are at particular risk, we need to know about that, and we need to adjust our treatment and prevention efforts accordingly. Just gender differences in susceptibility. A very recent study among high school students showed that, again, females had greater cigarette use, greater alcohol use, and were more likely to have smoking friends. And in line with Dr. England's talk just about all the marketing, I just wanted to bring up that really there has been much marketing towards women, much marketing towards younger women. And, as the United States has gotten stricter and stricter in its marketing, we all know that the companies have headed to other countries, and their marketing campaigns really do target women in many ways. One of the things that's for sure is that women, and there are numbers of studies that show this. Right here is a summary of 190 studies. This is looking at all kinds of ways of stopping smoking, either pharmacotherapy, various pharmacotherapies, just cognitive behavioral therapies. But basically, if you look across all these studies, women have more difficulty maintaining long-term abstinence than men. And if we just look at, again, this is similar findings in quit behavior across large population-based studies, pooled clinical trial findings, and international samples of naturalistic quitting. And you can see women have greater relapse rates, women have greater difficulty quitting, and less likely to achieve abstinence across multiple trials. So why is it that women have more difficulty quitting smoking? In spite of the fact that, just to go back to the other slide, women actually have more quit attempts in general than men, but are less successful. Well, there may be a couple of factors that underlie that at least should be investigated in terms of underlying this poor response in women. Could it be reproductive status and hormones? Could that have a large influence? Psychiatric comorbidities, many of which we know are more common in women than men. Weight management. We know that people gain weight when they lose weight sometimes when they start smoking, and gain when they quit. And then certainly stress and negative affect. So let's just explore. And then finally, medication response. So let's explore all of these. This is the menstrual cycle. The main thing to notice here is that in the follicular phase, we have higher estradiol, and in the luteal phase, we have higher progesterone. And so those are sort of the dominant. And then right here in this premenstrual phase, there's really rapid transition in the level of in the ratio of estradiol to progesterone is changing very rapidly during this period. And that is what people think is really the main cause. It's not actually absolute level of estradiol or absolute level of progesterone, but it's this rapid transition in the ratio of one to the other that seems to be a potent factor in premenstrual syndromes as well as postpartum depression, because we see the same sort of thing, rapid alterations in the estrogen progesterone ratios. But progesterone, as you all probably know, there's a fairly robust animal literature. Most of it is not looking at cocaine, but they're looking at not looking at nicotine, but looking at other things like cocaine, alcohol. But there are some very notable generalizations. Estradiol in general enhances drug reward and facilitates reinstatement. And progesterone, which is a neurosteroid, so it has a very calming, it's got a benzodiazepine-like effect, a very mild benzo, but it does dampen, it's calming, it's anxiolytic, and it does dampen drug-seeking behavior. So one would think, okay, well, that should lead us in a certain direction when it comes to smoking cessation in women. And the human laboratory research is pretty consistent with this. Most of it done by Mehmet Sofuglu at Yale, but he's shown in a number of laboratory settings that progesterone attenuates craving in nicotine dependence. It decreases the self-report of liking of IV nicotine and reduces just and increases cognitive performance. However, in this one very nice systematic review and meta-analysis, menstrual cycle and ovarian hormone effects on smoking. Again, 36 studies that looked at ad lib, cessation, relapse, withdrawal, and craving. Just looking here at the effect sizes, what you can see is there's more evidence that there's greater withdrawal and craving during the luteal phase, which is when progesterone is high and estrogen is low, as compared to the follicular phase. So this is completely inconsistent. So what I'd say right now, these effect sizes are not particularly large. And what I'd have to say is at this point, there is just not enough evidence to definitively say a woman should always try their quit attempt during the follicular phase or always during the luteal phase. It's just not clear. You would think the progesterone would be protective and helpful and decrease craving, but in fact, the data is just not supporting it. And the effect sizes aren't very large anyway. And when Sofuglu and others do their experiments, they use super physiological doses of progesterone. So it may be that really whopping doses of progesterone can do something, but we're talking about just what happens in normal physiology. I don't think this is a place to hang your hat. What about psychiatric illness? If you look in that column over here to the far right, that is the US population rate of smoking. And these are all different psychiatric illnesses: schizophrenia, bipolar, major depression, panic disorder, PTSD. You can see all of these disorders put people at incredibly high risk for the development for smoking. Now, why is that? Maybe there's some sort of shared genetic vulnerability. In some cases, like schizophrenia, maybe it's a self-medication. I mean, the schizophrenics have some sort of a neural gating disorder that appears to be corrected. So maybe their attention and stuff they're able to focus it better when they're smoking. People with anxiety disorders do report that smoking seems to calm them down. So it could be self-medication. It could be shared genetic vulnerability. It could be some sort of shared stress response, because we know people smoke in response to stress, and stress is often a feature of, and stress exacerbates and is a feature of many of these illnesses. But if we look here, this is just past year's psychiatric diagnoses and smoking in men and women. And what you can see is pretty much across diet that we know smoking is highly associated with these psychiatric illnesses. But what this tells us that it is more highly associated for women compared to men. So this is a huge point in terms of clinical relevance and important things to address when treating both men and women, but particularly important for women is that psychiatric illness is important and needs to be managed well. This major depression is probably the psychiatric illness. That and schizophrenia are the two that have been the most clearly studied or most frequently studied with regards to smoking. And what we're looking at, I think the top graph is the more important one. First of all, we know that people with major depression have a harder time quitting smoking than people without major depression. In the top, we're looking at males and females with current odds of daily smoking status by depression diagnosis. And you can see higher with current and lifetime and MDD. So women are, we know, twice as likely to have major depression compared to men. And when they do have major depression compared to men, they have stronger associations between smoking and major depression. So again, this is an illness that really needs to be aggressively addressed for both men and women who are smoking. Depression is associated with a decreased ability to quit for both men and women and increased likelihood of relapse. And how about just stress, just life stress in general? A number of people using both EMA in people's, real life and work environments. Also looking at human laboratory paradigms where you bring people in and stress them. And that, as well as just interviewing patients who smoke and asking them about precipitants of relapse. These are things that have come out very consistently, and that is that stress is a primary mechanism that's involved in the maintenance of smoking and relapse to smoking. And this is probably Saul Schiffman is one of the best, I think, earliest people to do this by monitoring people day to day, minute to minute in their working and active lives. Smokers, if you just interview, identify stress as a causal factor in most of their accounts of relapse. Most smokers believe that smoking is going to alleviate negative affect. So if they're not feeling good, one of the things they may want to do is turn to a cigarette. And smoking lapse if it's triggered by stress, progresses much more rapidly to a relapse. So somebody who's trying to stop, has a stressor, cigarette in response to that stressor, they're much more likely to sort of go all the way to relapse. And this is just looking at what is the stress differential in and stress smoking in men versus women. This is across several laboratory studies, smoking in women versus men, more likely to be influenced by stress and negative affect. What we're looking right here is negative mood reduces the latency in seconds to smoke in females. So this is in a laboratory setting. People they're shown scripts or personalized scripts, negative, positive mood, and then we look at latency to cigarette. And you can see there's no difference for positive mood, but big difference for women with negative mood. And these are two studies done by colleagues at MUSC, just looking, this is gender differences in craving and stress. This one is a laboratory-based study, and you can see for women, this is the smoking cues. They have higher stress, higher craving, but negative affect cues in particular, higher stress, higher craving, higher arousal. And this is using EMA, just smoking cues presented in the natural, and smoking and negative affect cues presented in the natural environment. And what you can see in general is that women have a higher response to both the smoking cues and the negative affect cues in their natural environment. And what about weight control? So as we know, this was one of the things that the companies were promoting for women in particular, that to keep a slender figure. So we do know that smoking can control weight, and that many women are concerned about post-cessation weight gain, and fear of that weight gain can inhibit quit attempts. So one of the things I think that's really important is in speaking to women about quitting and quit attempts is that need to identify whether weight gain is a cause, is something that's preventing them from trying to stop, and has it ever caused them to relapse in the past? And it's not that there's any particular easy answer for this other than to help people to anticipate it and help them to accept a small weight gain. If women report that they are willing to see a 5 or 10 pound weight gain in order to stop smoking, that they see the values of smoking cessation is that important to them, they are much more likely to have good smoking cessation outcomes. So medications, this is a really interesting area because I've been looking at gender differences in medication response to substance use disorders for quite a while, and it is very, very, very poorly studied. Most studies do not in the substance use disorder, well, in psychotropics in general. But the smoking area is probably the one area within substance use disorders where we have the most evidence and the most data. And wherever we look, we find gender differences. That's what's so important about this. So we just need to be looking more carefully and thoroughly at other medications that we use to treat other psychiatric and substance use disorders. But there are 3 FDA-approved medications for smoking cessation, multiple forms of nicotine replacement, bupropion, which is Zyban or Wellbutrin, so it's also an antidepressant drug, and then finally varenicline or Chantix. Each have a different mechanism of action, but one of the things we know for sure is that women do not respond as well to nicotine replacement as men. And again, this is 42 placebo-controlled clinical trials identified, 22 reported examining the treatment of outcomes by sex. And whenever men and women differed, women did more poorly than men, and virtually no differences in terms of compliance, side effects, withdrawal, or craving, but women just did not respond as well to nicotine replacement as men. Now, there's a couple of reasons why this might be true. One is just that men, it's Kelly Cosgrove and colleagues, again at Yale, have shown using PET and SPECT that men have upregulated nicotinic receptors in the right ventral striatum as compared to women. And so when men smoke, you actually see greater, if you see that graph on the right there, that there's much more activity in the right ventral striatal area in men than women. And if you look at this in abstinent smokers and you just look at binding by SPECT or PET's binding, you'll see much more binding in men in these areas of nicotinic receptors than women, meaning that there's upregulation. And when they stop, they're much more likely to respond to nicotine replacement because they've got because they're more sensitive to it. The other issue that's really important here is that women appear to clear nicotine from their systems faster than men, and in particular, women taking oral contraceptives. That's the far right bar. Okay, so let's move on to, so nicotine replacement should not be the first line for women. This is a meta-analysis of bupropion by sex, and what you can see is that there's increased rates of quitting in both men and women. Odds ratio is good, like 2 to 3. However, the rates of quitting in women in general were lower than men, but bupropion appears to be equally efficacious in men and women. And then varenicline. 2 large studies published in JEM indicated no sex differences in smoking cessation outcomes. And here is just looking meta-analysis of this data by sex. And what you can see is that men and women respond equally well, but women have less of a placebo response rate than the men. So again, varenicline is also very a good choice for women. And this is a network analysis combining multiple studies looking at varenicline versus by men and women. Varenicline versus nicotine is the first bar, the dark blue. varenicline versus bupropion, the light blue, and then nicotine replacement versus bupropion, which is the orange bar. And what you can see is that for men, all three are fairly equal, but for women, varenicline is actually better than bupropion, and bupropion is actually equal to the patch. This being said, we need to remember that bupropion is also an antidepressant, and depression is common in women smokers, so it could be a good choice for that reason alone. So let me just wrap up by saying, to improve smoking cessation for women, we really need effective strategies that address factors that maintain smoking: stress, psychiatric illness, weight gain, that sort of thing. We definitely need to target stress reactivity. And really, women do have more difficulty quitting smoking. Smoking cessation medications can help, but we need to be careful in our choice of those. Clinical care guidelines really should be updated to reflect this. And this medication development in the future really needs to take some of the stress sensitivity and gender differences into account. And with that, I think I will stop. I think we're going to take all the questions at the end. So I'm going to introduce the next speaker. And this is Diann Gaalema, who is an associate professor in the Division of Cardiovascular Medicine at the University of Texas Medical Branch, where she's the associate director of cardiovascular research. Her current research interests include secondary prevention of cardiovascular disease, with a focus on tobacco use and vulnerable populations. So, thank you.
I was going to say, it's always interesting to come after such a distinguished speaker and you look at their slides and say, hey, she stole that bit of my talk I was going to give, but oh, she did a good job, much better than I probably would have done. And then I have more time to talk about the other things. So there'll be a few things that I can gloss over a little more because they've already been excellently reviewed. And one of the things I was grateful for is that Dr. Brady also talked about gender and sexual orientation, because I know that's a big issue as well. And especially for this specific talk, I will be focusing on biological sex. So I am glad that was addressed. So for this talk, what I want to do is look at sex differences in the effects of smoking on cardiovascular disease, talking about why we see differential deleterious effects of cigarette smoking on the cardiovascular system in females. Here's my disclosure slide. I have NIH funding, but no conflicts to disclose. And there's some data in here from the AACVPR registry, and those are the disclosures that are associated with using the data from that registry. All right, so just an outline of what I'll be talking about, just a brief overview of cardiovascular disease and smoking, and looking at some of the sex differences in smoking and cardiovascular disease, talk about one potential mechanism of why we see these differential effects, look at rates of smoking by sex within CVD, the challenges in smoking cessation in those with CVD, and then a couple of implications for when we're looking at secondary prevention. So people have already had an event and we're trying to help them recover. Okay, so just your overall reminder about how bad smoking is for your cardiovascular system. So the dangers of combusted tobacco use on the cardiovascular system are well known. So we see endothelial dysfunction, blood vessel constriction, platelet activation, dyslipidemia, and creation of a chronic inflammatory state. And all of these things lead to these outcomes that we see, where we see acceleration of atherosclerosis, destabilization of coronary artery plaques, and these precipitate acute coronary events. And so as shared in the last Surgeon General report on the effects of smoking, it's estimated that 50 years of smoking have led to almost 8 million premature deaths due to cardiovascular and metabolic diseases. And of course, this number has only continued to accumulate since then. All right, so let's talk a little bit about what kind of sex differences we see in outcomes from smoking on the cardiovascular system. So generally what you see in the development of cardiovascular disease is you see this age gap in the development of disease. So if you look by sex at the age of, on average, of first myocardial infarction, the first heart attack, you see that it happens at about 72 for females and about 65.6 for males. So there's this gap. Men are more likely to develop cardiovascular disease. They develop it earlier. But But when you introduce smoking into the equation, it seems to eliminate that age gap. And when that males and females tend to have these first events at a much closer age than if smoking was not in the equation. So why do we see this kind of effect? One of the things we can do is look at the effects of smoking on particular types of cardiovascular events at different age groups by sex. So looking at this one study of about 25,000 people, one of the interesting things that they found is that when you're looking in people who are smoking on average about a pack a day, that the risk ratio associated between smoking and having a myocardial infarction is much higher in females when they're younger. So when you're looking at people that are age 25 to 54, that ratio is 3.8. When you get to 55 to 69, that ratio is 2.2. And then when you get above 70, then the hazard ratio is about 1.6. And you don't see this same pattern in males. The risk ratios associated with smoking and development of cardiovascular disease are much more equal across the different age ranges. So this seems to suggest that perhaps these deleterious effects of smoking on the cardiovascular system are kind of front-loaded for females, that it's having more of an effect earlier on, and that then would cause them to have those events sooner and bring the age range of first event closer together. So one of the things that we did was kind of look at I'll talk a lot about cardiac rehab because I love cardiac rehab, but so cardiac rehab is that you have a cardiac event, there's outpatient rehab that you can go and attend, and it rebuilds your cardiovascular system and reduces morbidity and mortality. But I have a lot of data from looking at cardiac rehab, and one of the things that we looked at is, do we see this age gap when we look at people who are entering cardiac rehab? So for a group of patients, we looked at carbon monoxide levels of people coming into cardiac rehab and differentiated based on whether they had higher or lower carbon monoxide. Higher carbon monoxide, we assumed that they were probably smoking. And we found this similar pattern there. The people that had elevated carbon monoxide, the age difference was lower. It was 63 instead of 67 for people that were in cardiac rehab, but there wasn't any difference in sex. So there was the males were coming in earlier than the females. It was equal for the people that had elevated CO. And when you look at the people that didn't have elevated CO, there is likely a difference. I have to go back and look at the data to double check, but I'm almost positive that it's there. All right, so not only do we see this kind of age gap that then seems to be erased by smoking, but we also see disparities in development of disease and outcomes between males and females who are smoking. So within those who smoke, females have a 25% increased risk of developing coronary heart disease than males. And it's not just the development of the disease, it's outcomes as well. So if you're looking at coronary heart disease mortality, the risk ratio for males is about 2.5, but for females, it's 2.86. So more likely to develop disease and more likely to have bad outcomes from those diseases. And we see even higher discrepancies between males and females when we look at certain types of coronary heart disease. So one good example of this is ST elevated MI, which we call STEMI. So this is already a cardiac event that is already very closely tied to smoking. Smoking is a huge risk factor for STEMI. But we see that for females, it's even more so than for males. So we look at the risk ratios of smoking on STEMI. We see a risk ratio of females at 6.62 versus 4.4 for males. And then once again, we see differential outcomes after these events, where we see higher associations between having STEMI and 30-day mortality in females as compared to males. So here, 3.86 versus 2.75. And this graph just kind of demonstrates what those differences in mortality look like between males and females for different age groups. And you can see that purposes here. You can see over here that within the females that are less than 60 years of age, that association between STEMI and mortality is really high, and it's less so in the greater than 60 years. So once again, reinforcing that idea that perhaps the risks of smoking are being front-loaded in the females. All right, so I'll talk briefly just about one of the potential mechanisms for the increased risk between cigarette smoking and adverse cardiovascular outcomes in females. So one of the potential mechanisms is that there's a connection between the use of tobacco, so use of combusted products, and nicotine, and estrogen levels and the risk of cardiovascular disease. So we know that there are various compounds in tobacco and tobacco smoke and nicotine that can affect the production and clearance of estrogen. So you can look at the hypothalamic pituitary ovarian dysfunction. And so we see that, nicotine here could be inhibiting secretion of particular hormones that are essential for the synthesis of estrogen. And then we can look in the liver and we see that there's compounds that we see in the combusted components that can induce the activity of certain enzymes which accelerate the metabolism and clearance of estrogen. And then see that in the aromatase enzymes are also working here, affected by nicotine and polycyclic aromatic hydrocarbons. And so this is also inhibiting aromatase activity, which is reducing the endogenous production of estrogen. So this is, the various compounds are decreasing production and increasing clearance, and so generally driving down estrogen levels. And so then we connect that back to the cardiovascular effects of reduced estrogen. And estrogen can play a pivotal role in various types of these very mechanisms that we see that increase cardiovascular risk. So we see that once again, if we have lower estrogen levels, that we're getting more endothelial dysfunction, we're getting more of this pro-inflammatory state, we're getting an altered lipid profile, and we're getting increased platelet aggregation, which you remember from that first slide I was talking about, these are the issues with combusted tobacco use that are driving CVD. This is a very similar list, right? So then what we see here is a kind of a synergistic effect where we've got potentially the smoking affecting the production and clearance of estrogen, which is then affecting these risk factors for CVD. And then the smoking itself is also increasing these risk factors for CVD. So that's just what that looks like as a figure. So here we have, kind of this 1-2 punch of potential effects on smoking on estrogen, and then estrogen on CVD risk, and then smoking on CVD risk, all leading to an overall double attack of increased CVD risk in females. All right, so to move on a little bit to rates of smoking and those with cardiovascular disease by sex. I'm sure you're going to hear a lot from various speakers, including the one that we just saw, about rates of smoking by sex over time. But just to remember, historically, males have been more likely to smoke, which may have, continued to lead in certain areas for more effort being put towards the issue of smoking in males. But we know that over the last several decades that the prevalence of smoking in the United States has generally dramatically decreased, but we see decreases that are happening faster in certain populations. So one example of this was the study that looked at NHANES data, looking at risk factors for cardiovascular disease by sex over time in US adults. And if you look at this, you can see that, here's current smoking here, right here. And you can see overall current smoking in adults is going down, but the gap is narrowing between males and females. Current smoking has been decreasing faster in males. And this is a pattern that we see in other vulnerable populations. So one example is in rural populations, females may actually be increasing in their cigarette smoking while the males are still decreasing. So in these certain vulnerable populations, we might start to see a switch where female smoking is actually the more prevalent than male smoking. And just to kind of reiterate the idea that we should be thinking of these as at least equal problems in males and females, we looked at some of the data from the nationwide cardiac rehab registry and just looking at what current rates of smoking were like. And when examining that database, which has over 400,000 patients across from certified registries across the nation, when you look at that, you see that there is no difference in the number of people that are reporting current smoking by males and females. It's almost identical, 7.6 versus 7.8. And I have to mention, this is probably a big undercount of the actual levels of current smoking that are going on in people that have had cardiac rehab qualifying events. But, you know, this is a thing that they're coming into these programs with equal rates of smoking. All right. So moving on a little bit to talk about the challenges of smoking cessation in those with cardiovascular disease. This is the part of my talk that has already been covered. I will just briefly go back over. So we know that there are efficacious medications available for smoking cessation. There are, multiple forms of FDA-approved medications available, including NRT, bupropion, and varenicline. And likely the best treatment for smoking is some combination therapy, maybe varenicline and dual-acting NRT, something like that. And we know that there's good efficacy and safety data on all of these medications, including in those with cardiovascular disease, including patients that have been hospitalized with cardiovascular disease. Everyone is checked out to make sure that we're not increasing cardiovascular events in people by using these medications. But because of some initial data that suggested that maybe that there were cardiovascular outcomes or psychiatric outcomes that were not ideal, there still has been strong hesitancy to use some of these medications, especially in patients with cardiovascular disease. So one of the ways that we can look at this is just look at what the prescribing practices are that are happening currently in different hospitals. So this is a study that was done by Quinn Pack, looking at almost 300 hospitals and looking at patients who were hospitalized with a diagnosis of coronary heart disease who are currently smoking. And looking at within that patient population, less than a quarter of the patients received any sort of medication for smoking cessation at all. And when you looked at what they were potentially receiving, 90% of those prescriptions were for NRT alone, and probably just single acting NRT, not even dual, not even short and long term, just here's a patch. And so this is obviously a group that is being undertreated. And I mean, this is something that I see clinically as well. I've had plenty of times where I've run into clinicians or nurses or whatever, and there's just strong hesitancy to use even NRT in this population. People, I mean, there are known nicotine effects on the cardiovascular system. We've talked about it a little bit already, but the difference between NRT and the effects of continued smoking are so stark that you think that they would still feel comfortable using NRT, but there's still great hesitancy. And so this is definitely the part that I don't have to talk about very much because it's already been covered. But I was mentioned in the previous talk, this reliance on NRT in the people that are getting prescription is perhaps troubling when we're talking specifically about smokers, female smokers, because it seems that NRT is less effective for females than it is for male. And we talked a little bit in the previous talk about why that might be. That females may be less sensitive to pharmacological effects of smoking or of nicotine. They may be metabolizing nicotine faster than males. And that kind of gets compounded by if they are metabolizing nicotine faster, then they're probably also more likely to be being underdosed and so not have an efficacious dose of NRT to begin with. And so, yeah, this data was already shared, but it just shows that if we're looking at females, that there definitely is better data to suggest that varenicline is the better choice and that both NRT and bupropion are not working very well for this particular population. Oh, and then when as was shared before, yes, that we don't see that same difference in males, that most of these therapies are working pretty equally. But yeah, but on the flip side, then that does give us kind of a goal, right? We can look at the other medications for smoking cessation and see, is there a better option? And this is another view of that data that was shared in the last talk. But we do see that there does seem to be better effects for using varenicline in females than in males. So here is the weighted odds ratio for that, almost 5 in females. And here we have in the males over at 3.43. So this is a medication that seems to actually be working better for females than for males. So the issue then, if we're continuing to rely on NRT for treating smoking in females with cardiovascular disease, we may be inadvertently continuing to widen the sex disparities in outcomes for cigarette smoking. Okay, so to talk a little bit about implications for secondary prevention in cardiac rehab. So as I mentioned, cardiac rehab, this is a place you go to rebuild your cardiovascular fitness and improve your outcomes following having certain events like myocardial infarctions. And we worry a little bit about how people do in those programs. It's very important that they improve their cardiovascular fitness. It's a big indicator of how they do long-term. And so one of the things we become concerned about is that, are there certain things that people are doing that are impeding their ability to improve after they've had these events? And smoking seems to be one of those ones that could potentially really impede people's progress in recovering from having these events. So this is just an example looking at changes in peak VO2, which is a measure of your cardiovascular fitness. And ideally, greater change is better. And this is looking at over about 2,200 patients. And this is pointer here. We got age across here, and this is change in peak VO2. And as you would expect, as you get older, it's harder for you to improve your fitness. So you have this general downward trend. But when you're looking at smoking status, here we have the current smokers here in this line, this bottom line, and you can see there's a clear shift that the people that are currently smoking when they're entering cardiac rehab are improving less across the age range in their peak VO2. Interesting, there was not an effect of sex on this improvement, so smoking was just equally bad across the board for people improving their cardiovascular fitness. And so one other note, I'll look once more about, do we see, what kind of sex differences do we see in people coming into cardiac rehab that are smoking? So one other study that we did was looking at carbon monoxide. As I mentioned briefly before, we measured carbon monoxide on over 1,000 patients who were entering cardiac rehab. Over 300 of them were female. And we were really focused on people that were at risk for smoking. So people, we chose a cutoff of a carbon monoxide of greater than or equal to 4, which is a little low, but we were interested in not only people that are smoking, but also environmental exposure, secondhand smoke exposure, that kind of thing. And a couple interesting things came out of this. Once again, we see one more of these indications that the smoking rates, this is an equal issue across males and females. So we saw equal rates of people who had elevated carbon monoxide levels coming into cardiac rehab. It was about 15% for both. But when we went to look and examine differences by sex, we found, kind of interesting that if you look at people that came in with a carbon monoxide that was elevated, it was at least 4, that the females had these carbon monoxide levels that were more than double that of the males, which to us is interesting because if anything, females should have lower carbon monoxide levels because they clear these things faster with smaller lung volume and blood volume and stuff. So the higher CO levels suggest either, I don't know, that the males have higher rates of environmental exposure or that the females are smoking more cigarettes. It's one of the other, but on either way, it does suggest that there is some additional risk for our females entering cardiac rehab. And so, and there's additional information that you could see about the effects of smoking on outcomes in cardiac rehab and pulmonary rehab. So I'll just end by putting a plug in here for a couple of posters that will be at the poster session this evening, where we, as I mentioned, there's that nationwide database that we're looking at for cardiac rehab and pulmonary rehab. And these 2 posters dive more into depth in the outcomes we see, how smoking affects how people are recovering and potential sex effects of those outcomes. All right, and that's all I have. So thank you, everyone. Just acknowledge all of my clinician and research staff and trainee help. And there's the giant list of references that I can share if anybody actually cares.
And again, we'll have time for questions at the end, but I'd like to introduce right now Dr. Katherine Menson, who's going to be speaking about smoking and pulmonary health in women and girls. And she's an assistant professor with the University of Vermont, Larner College of Medicine, and a critical care medicine physician at the University of Vermont Medical Center. She serves as the director of pulmonary rehab. She earned her DO at the University of New England College of Osteopathic Medicine, and then came to the University of Vermont for postdoctoral training. Completed her residency training in internal medicine in 2016 and fellowship
in pulmonary medicine and critical care in 2019, both at the Larner College of Medicine. She has extensive experience in pulmonary health, and her recent research in studying the pulmonary effects of long COVID was featured in an article by Vermont Digger in 2022. So you're going to have to tell us a little bit about that as well, Kathleen. Thank you.
All right, thank you very much. I appreciate the opportunity to be here. I also want to thank the previous speakers for setting up nicely into some of the stuff that I'm going to delve into. So these are my disclosures. I have some personal salary support from the NIH and the American Lung Association, but I have no financial conflicts to disclose. So I think we saw this graph earlier. We know that the rates of smoking in women are declining as they are in the general population, but at a slower rate for women than they are for men. Men are declining at a rate of about 59%, 66%, and females at a rate of about 59%. And then, I'm going to be getting into pulmonary health and the exposure to smoke. So really important to also be talking about secondhand smoke exposure. So we know that the largest demographic that's being exposed to secondhand smoke exposure is the younger population, ages 18 to 39, and slightly higher in women than in men at 26% versus 25%. But also this is disproportionately higher for non-Hispanic Black females. We see kind of across the board, both males and females that are non-Hispanic Black. So that disparity really disproportionately affects people depending on ethnic and racial backgrounds. So I just want to do a little review of pulmonary anatomy and why it matters when we're talking about pulmonary health and smoke exposure. We heard some great information about kind of fetal development, but in thinking about more grown and developed lungs, I'm going to see. Okay, I'll walk you through this. So we think about smoke exposure and obviously first entering the nasal passages and the pharynx and traveling down into the main trachea and bronchi. And so think about these large airways. If you remember way back when from anatomy classes, that the large airways are really defined as being held open by cartilaginous rings. So they really have rigid support. They're not prone to collapse. They're going to stay open and patent kind of regardless of the damage that is done. But as we continue to go further down into smaller segments, you see these dots disappear and we turn into the small airways, or what we call the bronchioles. So those are really the airways that are held open just by smooth muscle support, but are at risk for collapse and spasm. And then as we transfer even further down, we get into the alveolar ducts and alveolar sacs, which is the very thin-walled single cell part of the lung where oxygen transmits into the bloodstream and carbon dioxide transmits out. So that's the anatomy of the respiratory system. Then we're thinking about the cardiovascular system, which is just as important. And remember, the only place in the body where pulmonary arteries carry deoxygenated blood is here carrying to the lungs. And we break down into smaller segments until we hit the alveolar capillary bed. So that capillary bed is surrounding those air sacs, which is where the diffusion takes place, and then takes that oxygenated blood back through the pulmonary veins to the heart to be transmitted out into the body. So it then makes sense that particle size is deposited in different areas of the lungs. So if you were affected this summer by the wildfires or in previous summer, you might already be familiar with some of this information, which is that not surprisingly, the upper airway, so thinking about the nasal passages and the pharynx, is anatomically designed to filter out those larger particles. So things like road dust and pollen are larger particles. They're more likely to be absorbed in the larger, in the immediate airway passage. And then the really, really, really tiny particles also probably hit some of the cilia that are in the upper airway, get caught by mucus within the upper airway, but not so great at kind of these medium-sized particles. Those tend to be deposited and diffused in the tracheobroncho tree. So again, those rigid support with the cartilaginous structure, and then all the way down into the alveoli. And those particle size tend to be those 2.5 micron size particles. And that might sound familiar because that is where we are talking about systemic inflammation and damage in the body and things that were getting absorbed with smoke exposure, whether that be pollution or tobacco smoke. So this matters because it contributes to the development of smoking-related lung disease. And I think most of us think of chronic obstructive pulmonary disease or COPD, but I just wanted to make sure we're all up on the same page that it's really more than just a small airway problem. COPD is an umbrella term for the development of chronic bronchitis, emphysema, and asthma. And so that develops because as people are exposed to smoke, there are a number of ways that the symptoms can manifest and that pathogenesis occurs. So in chronic bronchitis, again, we're thinking about those large airways. This figure represents those cartilaginous rings that are supporting and keeping open the airways. But that ongoing smoke exposure produces mucosal edema, so swelling within the airways. The airway lumen gets smaller, and we get mucosal gland stimulation. So there's more mucus that's being produced within those airways. So this is how chronic bronchitis develops, and really is what we call the smoker's cough. So why people are kind of have chronic cough with smoking. That doesn't necessarily mean it's a problem within the small airways. That's really that different mechanism. And like I mentioned, smoking predisposes those small airways to have mucus gland hyperplasia and overproduction, and then also causes those small airways to become weakened, so more prone to collapse in those small airways. And what that does over time is then prevents air from exiting those alveolar spaces. So we get destruction of the alveolar space. And if you can appreciate in this figure, there's this nice healthy alveolus here, and then a lot of breakdown and hyperinflation or overdistension of that alveolar sac, and that reduces the amount of surface area in which gas can be exchanged. So this is how emphysema develops. So we're thinking about all three of those things. And then how do we define and grade COPD? Well, COPD, thinking about small airway involvement, really requires a specialized pulmonary function test called spirometry that's generally readily available at primary care offices or a specialized PFT lab. But going back, thinking about those small airways and air getting trapped in the alveolar sac, and thinking about that small lumen, if you can think back to physics, air can eventually get out, right? It just takes longer because that lumen is narrow. And so we grade COPD based on how much air a person can blow out in the first second, or what's called the FEV1. And so the longer it takes for you to blow out air, the lower your FEV1 is going to be. And so we grade it based on staging. This is defined by the Global Initiative for Chronic Obstructive Lung Disease, or the GOLD guidelines. And so if you can blow out about 80% or better, we think that we define that as mild. And then if you're blowing out less than 30% in that first second, then that's very severe. And so we know that lung function naturally declines with age anyways. So up here is a schematic of general representation of population of what can happen naturally with lung function in people who have not smoked. Now, there are other things that can cause lung function to naturally decline, like we've heard about, so prematurity or asthma, and that would be kind of in the non-smoking population. But in general, we don't start to see a significant cutoff till probably around age 70 or so. However, in those who smoke, we see that lung function declines much more rapidly and probably starts around the age of 40 or 50 and steeply declines. Now, if someone is able to quit smoking, say at age 50, their lung function starts declining at the rate of the normal population, although their starting point is much lower. But we know that the longer it takes for someone to quit, so if they quit at an older age and have more severe impairment, their rate of decline actually goes down at a steeper level. So the timing of when somebody quits smoking is really important. We also know that the recognition and treatment of COPD can provide some benefit in preventing lung function from declining at a faster rate. So identifying the diagnosis and getting people on treatment is a really important piece of this. However, we know that women are less likely to be diagnosed with COPD. So there's a disparity in the diagnosis based on examination alone, and this probably gets at a little bit more of the implicit bias of when we think about smokers, those who smoke, we are probably automatically thinking of a male when we know that this also affects females at the same rate at this point. So this was a study that was performed in North America and then replicated in Europe, looking at the rates of COPD diagnosis based on a standardized patient evaluation based on history and symptoms was pretty classic for COPD, and had primary care physicians kind of assess and make a diagnosis based on the history and physical exam alone. And so looking at this chart, the study found that males were much more likely to be diagnosed than females with COPD. And so starting with the North American study are these two left bars. So you'll see males in black left that visit with a diagnosis of COPD about 65% of the time, whereas females were only diagnosed about 50% of the time. And the numbers were much worse in Europe. About 40% of the males left with a diagnosis of COPD and probably about 30% of the females. However, if testing was appropriately ordered, so if patients were then sent for pulmonary function testing to assess whether COPD was present, that disparity went away. So physicians were accurately able to identify the presence of COPD with testing. However, only about 20 to 30% of primary care physicians order pulmonary function testing to make the diagnosis of COPD. So if we're not getting to that diagnostic testing, we're missing this gender disparity. And then we also know that women with COPD have more severe symptoms. And so we heard this already in kind of different flavors. But it stands once you have the diagnosis of COPD. So COPD symptoms are classically defined as shortness of breath, chronic cough, and sputum production. It's kind of the triad. And so we know that when we look at each one of those symptoms in women with COPD, they're more likely to have severe symptoms than their male counterparts. We also know that the airways in women with COPD seem to be more hyperresponsive. So there's provocation testing we can do to say, okay, to provide an irritant, in this case, it would be called methacholine, and looking at how reactive that the airways are and how well they blow out air in that first second, or that FEV1. And so we know that females with COPD respond in a more quicker and aggressive manner in terms of airway hyperresponsiveness. And that is important, one, not only because that's a risk factor for developing COPD, but that also has implications in terms of lung function and rate of decline of lung function in COPD. We also know, we heard this again in people who don't have COPD, but holds true for women who have COPD as well, is that depressive episodes are twice as high in women with COPD, and they have 50% higher rates of anxiety than male counterparts. And I guess not surprisingly, this all relates to a worsening health-related quality of life metrics. And this stands even when we control for the severity of COPD. So even if women have the same FEV1 as their male counterparts, their health-related quality of life is poorer. So I want to transition now into lung cancer. And again, I'll just reiterate that despite the fact that There tends to be a gender bias in who we think is at risk for lung cancer. Lung cancer deaths have accounted for more cancer deaths than any other cancer in women since 1987. So we often think of breast cancer, which of course smokers are at higher risk for. Those who smoke are at higher risk for. But we know that lung cancer deaths have really taken the lead for almost 4 decades now. We know that the 5-year survival rate is really poor. It's about 27%. And the only other cancer that is higher than that is pancreatic cancer. And we know that women, for some reason, have a predilection for lung cancer, even if they are not smokers. So women have twice as likely chance of having lung cancer as their male counterparts in those who do not smoke. And we know a little bit about this, and I'm going to give you the simplified version of what Dr. Gaalema was saying, which is that it appears to be in some part due to tobacco detoxification and the genetics that are at play here. So when we think about the lungs being exposed to carcinogens, they are immediately broken down by phase 1 metabolic enzymes in the CYP450 pathway. And so those carcinogens are developed into a metabolically intermediate species. So they're active and they're more unstable. Those are then broken down by phase 2 metabolic enzymes into the actual inactive metabolites and then are excreted. So that's how the body would normally react to carcinogen exposure. However, we know that phase 1 metabolism is higher in females. So females are more likely to be breaking down the carcinogen into these active, unstable metabolites, but not necessarily having more phase 2 metabolism. So we've got the inactive properties that can then lead to more DNA damage and then develop into lung cancer. We also know that regardless of gender, there's a null expression of phase 2 enzymes in about 50% of the population. So there are potential pathways here where females are, again, expressing more phase 1 metabolism and then may not even have as much gene expression for phase 2 metabolic enzyme breakdown. And this is represented by one of the CYP pathways that found that in patients with lung cancer, females had a much higher level of that phase 1 metabolic enzyme level than males did. And then we know that there are also molecular factors leading to lung cancer diagnosis. So there's a very well-known tumor suppressor gene called the P53 gene, in which regulates apoptosis or programmed cell death when there's exposure to cell damage. So we think of oxidative stress or radiation or chemotherapy that can, sorry, I got on another. Let's see my mouse. Okay, perfect. That can, when a DNA becomes damaged, P53 comes in and tells the cell to undergo programmed cell death so that further damage doesn't occur. But we know that in females with lung cancer have higher rates of the mutation of P53, meaning they're more likely to not be able to undergo programmed cell death. And that's even though, despite the fact that females have a lower pack year history of smoking exposure than their male counterparts. We also know that a lot of information in lung adenocarcinomas, which is a type of lung cancer, in terms of proto-oncogenes. So genes that normally are in the cell and act in beneficial ways, but if mutated can, again, lead to the risk of cancer being higher. And so we know that the KRAS mutation is higher in females at 26% than in males. So genetic factors that can predispose females to having lung cancer. And then we've already heard today about estrogen, but that also can cause problems in the development of lung cancer. So we know that estrogen receptors are expressed on lung tumor cells, and that estrogen probably contributes to lung maturation in some ways. When lung cancer cells in vitro are exposed to estrogen, there's a 17-fold increase in cell proliferation, which could have potential implications in the development of tumors in vivo as well. We also saw this, there's a pretty famous study that was published in the early 2000s called the WHI, in which we looked at postmenopausal women who were taking hormone replacement therapy to help with postmenopausal symptoms. You've probably heard this study in reference because it was really what acknowledged the increased risks of breast and endometrial cancers in women who are on hormone replacement. But in that study, we also found that there was a 50% increased risk of lung cancer. So knowing that estrogen probably is playing a role in the development of lung cancer and propagation. I just want to take a note and add what Dr. Gaalema had said, which is that these are epidemiologic studies, and we really can't extrapolate what this means in individuals who are taking estrogen supplements for other issues, whether it be for transgender care or for other types of treatment of diseases. And also just acknowledgement that the WHI study was much higher in terms of estrogen delivery than we typically use for other types of issues at this point, but also a potential area of future research. And then we heard a little bit about asthma, and I can't remember if we saw this slide as well, but just pointing out that we know that asthma control really plays hand in hand with smoking or secondhand smoke exposure. So thinking about girls and adolescents, we know that boys are more likely to be diagnosed with asthma in childhood. We don't really know why. Again, could it be a genetic predisposition? Is this a bias in diagnosis? Are girls less likely to be diagnosed? But we know that dynamic shifts. And again, whether this is related to estrogen, seems to shift kind of in early adolescence and young adulthood, where females really start to overtake the diagnosis in a 2-to-1 fashion of asthma. We do know, and again, we've heard about fetal maturity today, that prematurity and secondhand smoke exposure are risk factors for developing airway disease. And then similar to COPD, as women develop asthma in young adulthood, we know that their symptoms tend to be more severe and more difficult to control. So not only are they accounting for a higher rate of the population, but they tend to have more severe and difficult to control asthma. So with that, I would just like to wrap up some key points of my lecture, which is that females tend to have more severe manifestations of pulmonary disease across the board. So COPD and asthma, and it's felt to be due to the role of estrogen in lung maturity and estrogen receptors. Also recognizing that women are less likely to be diagnosed with COPD, which may contribute to the decline in lung function and worsening control. And then women are more susceptible to carcinogen exposure due to phase 1 metabolism and therefore the risk of lung cancer. And that's all I have. These are my citations. Thank you.
Okay, I think we're happy to take any questions or comments.
I'm just going to add that I'm happy where our talks overlapped, that we were
Yeah.
presenting pretty much the same information.
Well, that's exactly right. And I think it's actually good coordination to have things a little bit of overlap. Don't you think? I mean, it means there's sort of, yeah, I like it. Yep.
cessation treatment into COPD treatment, asthma treatment, cardiac rehab, or are we missing opportunities?
We are definitely missing opportunities. I think there's actually, a fascinating relationship between smoking and cardiac rehab and pulmonary rehab. So like you said, it does seem like a golden opportunity, right? This is for cardiac rehab. We have patients that have recently had some sort of event that's only going to be made worse if they continue to smoke, and they're coming someplace and people are saying them repeatedly multiple times a week, sometimes for, a couple of months. So it's a great opportunity. But that being said, smoking cessation is not integrated well into cardiac rehab. There are some programs that do a good job, but they have a tobacco specialist. They do prescriptions in-house, that kind of stuff. That is very rare. For most cardiac rehab clinics, you are required as part of the certification to ask about smoking status. And that's your competency, is that you have tracked it, you have asked about it and tracked it. And so I think there is a lot of opportunity for improvement there. So that was one of the things I was mentioning, is that we got carbon monoxide monitoring integrated into our cardiac rehab clinic, because that was one of the things that was important to me, is that we don't have an objective measurement of this risk factor that is so huge. We've got people coming in, of course, you get cholesterol levels on them, you get blood pressure, you would not get self-report on these kind of risk factors for people, but we don't do that for smoking. So that was like one step that I tried to make in that direction, but that's it's an ongoing process. And pulmonary rehab's even more interesting.
Yeah. Thanks. So yeah, I'm the medical director for pulmonary rehabilitation here at UVM, and smoking, I think very similar to cardiac rehab, has been shown to be a factor that prevents enrollment, and it's unclear really whether that is a bias from the because you do have need a prescription for cardiac and pulmonary rehabilitation from a healthcare provider. So unclear if that's a barrier just from getting the referral. I think, there continues to be this stigma, and we've talked a little bit about this in terms of people feeling like they've done this to themselves. But as Diann alluded to, we have some data that we just went through on the registry that really the outcomes do not appear to be, at least in pulmonary rehab, those who smoke achieve the same benefits as those who don't smoke. And so it really should not be a hindrance.
Yeah, I mean, the thing that I was thinking about specifically was that there are pulmonary rehab programs that don't take people that currently smoke. Like, you're not allowed to go to pulmonary rehab if you smoke. This is not all the programs, but there are programs like that. And so it's just a complete exclusion from the process altogether.
Right. But so the programs themselves, the way they're formatted, don't seem to improve smoking cessation efforts. But the question is really, are we doing it the right way? So, yeah, thank you. Thanks. You can tell that's our soapbox.
Don't hesitate.
Just give me another hour. I can talk about it.
I was just fascinated by these talks, and as a psychologist, I knew less about the cardiac and the pulmonary than the psychiatric. So my question is going to go in that direction. So a bit of a wonky question, and I was just fascinated. I didn't know about females being at greater risk for lung cancer independent of smoking. So the wonky question is, have they sorted out is it an additive effect? So you have the sex or gender effect, and then we know that you have a lung cancer risk associated with smoking. Are those two just adding up such that females are more likely, who are smokers, more likely to get lung cancer? Or is there like a synergistic effect where the cancer risks associated just with smoking is greater in the women than the men, even after you control for the sex risk?
I mean, I think what I can say about that is that the evidence about the fact that, so the genetic predisposition because of the, molecular factors that are increasing the risk of lung cancer alone. And then the fact that we add, estrogen receptors onto those tumor cells, I think probably does synergistically increase the risk of lung cancer. But I don't know off the top of my head whether we officially know that.
Yeah. If you don't, it sounds, seems like a good research project.
It
but-
does, it does, it
but-
does.
But
Yeah.
it's fascinating too.
For sure,
and-
for sure. And I think that, there is really strong evidence that, I mean, not surprisingly, but there's like a 23 times increased risk of lung cancer in women who smoke versus women who have never
Yeah.
smoked.
Yeah.
So, obviously the exposure to cigarettes is the big driver there. So.
And each of the presentations added on this reason. Why would we be looking at women only in this conference? Well, you provided many, many reasons. A wonderful, wonderful presentation.
Thank you. I was just going to add that I thought it was interesting. I hadn't seen your talk before this, but the fact that, there's evidence within the lung that the increased estrogen or the increase of estrogen receptors on cells promotes lung cancer development, but then the suppression of estrogen from nicotine is an interesting effect on the cardiovascular.
Right. No, it's interesting because it was a combination of you're reducing the production of endogenous estrogen. And then there's also some evidence that if you're providing estrogen from external sources, and that also further decreases your endogenous creation of estrogen. So these different sources have different effects. And so, yeah, I was happy that the hormone thing kind of went through all
Different
three
phases. Yeah.
But yeah, no, I enjoyed the opportunity to really delve more into the sex differences in cardiovascular disease and smoking, because I know, Steve had asked about this area and was like, I don't even know if there are sex differences.
Find it.
We're gonna find it.
Yeah.
I can't resist asking more questions, but please, I don't want to monopolize. But the difference in the timing of the diagnosis of COPD and the sound, if I understood you right, that some of that was just the physicians, healthcare providers not doing the thorough exam, or and my question is that sounds like a great research topic as well. Is it still occurring? Is there a decay over time in that bias to not do a thorough exam in women? And is there a difference in the sex by sex of the provider, or what's known about that? Because it sounds like a really important research issue.
Right. I'd like to add, and anyone who wants to add any additional information, is I think that because of the coexisting depression and anxiety, females are more likely to be diagnosed with having shortness of breath or symptoms that might be related more to a mental health disorder than an organic. And I don't mean that in any, I'm saying that as a physician myself, right, in a non-disparaging way, but I think it can be really difficult, even as a pulmonologist, to tease out when somebody's shortness of breath is related to their anxiety or to underlying disease. But I think, the overall take-home message is that we actually need to be ruling out and addressing whether there is disease present, right, at equal opportunities.
Yeah, because if you look at the cardiovascular side too, there is also this underdiagnosis of acute myocardial infarction, those kind of events in females as well. And some of that seems to be because the symptoms that they show are different than males, and the way of diagnosing these disorders was based on the male symptoms. So I was curious that as well, whether COPD is showing up slightly differently, and it's that similar kind of disparity.
Well, and I think it's, the severe manifestations of it. And it kind of gets to the question I asked earlier to Dr. England of, my practice and what I see is that really patients are self-treating. And when we have, particularly females who have been dealing with anxiety and been using cigarettes to treat their anxiety their entire lives, what lengths can we go to really get them adequate treatment earlier in adolescence or young adulthood so that they don't start using nicotine as a treatment for that? So.
And I will say that the whole anxiety, depression idea goes throughout all of these talks and some of the other outcomes we have as well. So like I said, check out the poster session for some of the stuff there. But one of the interesting things is to see, how being female and smoking affects your outcomes. And we see this differential outcomes on improvements in depression in cardiac rehab. But these are disparities that are more than just the usual medical outcomes, but potentially psychological outcomes as well. So I'm really happy we're in with the psychological.
We have a question online. What studies would you propose to learn about the potential implications of hormone blockers and hormone replacement therapy, specifically within the trans community on smoking cessation treatments?
That's a great question. I think we need to know a little bit more about differential prevalence and risk factors among these different groups. So that's sort of an emerging database that I think is, until we know more about that, I think we don't know whether we need to really develop specific treatments. I mean, that one study looked kind of like a crazy, increased prevalence, but maybe that's related to anxiety around gender transition. I mean, but if I'd have to say, just looking at the hormonal fluctuation data and smoking cessation for women, I really think effect sizes in there are relatively small. And I think if you get a good medication, you just knock that, you know what I mean? I think that will just overpower hormonal, any sort of hormonal impact. But I don't know. That's on treating and relapse. I'm not sure what you would need to do at the front end of that around helping people to not smoke or not initiate, which I think is more what the question is about.
I mean, that might be one of the places where, the animal studies would be useful, because then you could do the more controlled manipulations of hormone levels and start there. So I would think that maybe that would be where you would start with looking into that stuff. It's relatively new. So we're gonna have to wait a little while for some of the data to accumulate on the longer term effects of these treatments.
We have another online question from Rhonda Williams. Dr. Benson, do you think there's a role or opportunity for public health to increase diagnosis of COPD among females through more education and sponsored clinical training or other pathways? And ideally, public health can help to increase successful cessation among females in pulmonary and cardiac rehab, and through adjusting quit lines. Add Varencline to the benefit as one example.
I certainly think that empowering patients and the general public to know about the risks of smoking and the potential outcomes. I mean, similar to what I believe it was the American Heart Association that really pushed the risk of cardiovascular disease in women.
Yeah, made a whole month of
Right. The recognition of the fact that these, and especially actually in lung cancer as well, is that this, really does have gender differences and things to be thinking about in terms of risk of disease and then identification of disease. I'm sorry, I forget the second part of the.
Whether we could, if there was a role for perhaps for quit lines for improving smoking cessation in cardiac and pulmonary rehab.
You want to take?
I mean, I know that we have struggled a little bit to integrate external tobacco treatment into cardiac rehab. I was going to say, is Jason still here? So Jason Rango, who was here earlier, actually looked into this a bit to see what happened in cardiac rehab for patients that were referred to tobacco treatment, quit line kind of thing, and just found really bad uptake of the patients that were referred. And it seemed like, I don't know, either that the quit line reached out to them and then they never reached out back, or they, there wasn't enough trying to get them engaged, it was, I guess, a little too much light touch for that particular patient population. So I'm not exactly sure what the answer is, because it seems that the quit line hasn't been doing so well for these patients. And there's the added issue of, stuff that the quit line can do for other populations they can't necessarily do for ours, because you have to get referrals and sign-offs to get NRT from the quit line, which is another added barrier. And so it's just not a smooth process the way that it is. And I don't know how to fix it, but I know that it's not what we need right now.
I was just going to add, if you don't have anything, Dr. Brady, that, I mean, when I think about fixing this issue, and really meeting the needs of these patients, I foresee, basically a case management style, that the needs of the population, who are still addicted to nicotine and who are still smoking, are very high. And that it's not going to be fixed with a single referral in the electronic medical record. That it really takes someone helping them navigate the things that they need to do, like lung cancer screening and attending, pulmonary or cardiac rehab, and getting help with getting their nicotine replacement or their varenicline. It just seems like a full-time position for someone.
The other thing I think to add to that is that there's a lot of data that, in addition to women's the rate of decline being less, that other social determinants of health are very powerful in slowing that decline, and that includes poverty and job loss and other kinds of things, and access to medical care. So I really do think this is a population that the still smoking population does have multiple needs, and probably case management is a reasonable thought.
Yeah, I was gonna say, just to go off of Dr. Menson's comment that this is a full-time job, I will say I do know of one clinician that has pretty good success with smoking cessation with his cardiac patients, but he has a very hands-on approach, and he's willing to write all the scripts. And if one thing isn't working for you, then you're going to adjust the dose and try something else. And this is just like an ongoing process that it's not just a one and done, but it takes a lot of effort.
This is, I'll make a comment, and I'd like to hear from any of you or all of you on it. But I was struck by Dr. Gaalema's point about that you had breath CO monitoring integrated now in a cardiac rehab, which, it could sound like a small accomplishment, but I know from my own experience, it's not a small accomplishment. And so I'm curious what more can be said about, is it in pulmonary rehab? What about psychiatric sessions or whatever? And you remind me of an experience I had first time I got a grant to do smoking cessation in pregnant women. I met with a leader in obstetrical care, and I knew about what Lucy mentioned, the underreporting and this and that. Mm-hmm. And so I mentioned the possibility of doing breath CO with the obstetrical patients, and the response, I was just early in my career, I was stunned by the response, which was, we could do that if all we had to do was the test, but there are going to be questions about the test results. We don't have the time to allocate to that. And that is as true as I'm standing here. I was just stunned and thought to myself, what pressures they must be under that they have to worry about something like that.
But on some level, it just doesn't make sense, because what if they had a high blood pressure in that obstetrics? Would they, they have the time to deal with that?
That's the other one, is like, what things are they allocating the time to that are less important on the pregnancy than smoking? So just see your thoughts on any of it.
The only thing I could say, just when I hear you all talking about is how well integrated smoking cessation is into cardiac rehab or pulmonary, I think about my psychiatry experiences and how many psychiatrists just absolutely, you saw the numbers, it's phenomenal what the risk of smoking is for both psychiatric disorders, and psychiatrists, I think by and large, do not
treat smoking. They don't do smoke. We don't do smoking cessation. You know, I mean, that's it. I mean, they will refer elsewhere, which just seems, this has always seemed crazy to me about psychiatry in general since the beginning of my career. It's not substance use disorders or psychiatric. Substance use disorders are part of the DSM. They are psychiatric disorders. If you're treating psychiatric disorders and 50% of your people have a comorbid substance use, you need to treat that. I mean, that's just, but it's just not done. And I'm not sure fortunately the first year ever, we have an APA president who is a substance use disorder expert, and he's really trying to raise the awareness about that. But the only other thing I have to say about that, just sort of bitching about my own profession, but I was head of the AAAP when the whole parity thing came out, and it was being under discussion the first time, and APA was in there on the, right at the front lines, and AMA and AAAP, and APA was perfectly willing to throw substance use under the bus and say, if we can only get this covered, that's fine. No substance, they were perfectly willing to say, we'd like to see coverage for psychiatric disorders, and you can exclude substance use as far as we're concerned. So it's a real uphill battle everywhere,
I mean, there's an interesting historical perspective for psychiatric disorders and smoking as well,
Yeah.
right? Back from psychiatric hospitals and cigarettes being given out, and then just kind of the ongoing idea that if you treat one of these things, the other one will get worse. So like, you don't want to take them both on at the same time. And
Right.
even though we know that there's no data that supports that,
Right.
but the idea is still there. It's these clinical myths that are hanging out, like the NRT and the cardiac patients.
What do I want to say about this? I think what I want to say is that it is an interesting point in an issue that it doesn't feel like any one specialty's responsibility, when really it should be everyone's responsibility. I also think that training in medical school or in nurse practitioner school or PA school, in terms of really having more robust education on ways to help people quit, in reinforcement of that in training. And then I think just acknowledgement of, and I think I don't know, maybe we're getting there, maybe we're not, but the reimbursement model for taking the extra time to identify that this is a problem and spending time with that patient to get them to quit, or the support within a medical home or a specialty center to have a tobacco treatment specialist then be flagged as this patient and ready to come in and talk with them and spend additional appointment time. I think there are just a lot of ways that we could better support this patient population in ways that aren't being done. So.
Always more to get to.
Always.
All right.
Thank
you
you
very much.
So officially lunch starts at 12:15, so we're going to get an early